Good evening and welcome, and thank you for attending our Head of Cancer lecture series this evening, sponsored by Allegheny Health Network Cancer Institute. My name is Margie, and I'm the Director of Nursing for the Cancer Institute. Here are a few housekeeping items we would like to review before we start. During the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time permits. Participants cannot speak during the conference, but again, we encourage feedback via the chat option. Tonight's lecture is being recorded. If you're interested in rewatching this lecture or any of our past lectures, please check out our AHN YouTube channel. The entire lecture series is posted under the Head of Cancer playlist. Lastly, if you would like to schedule an appointment or have any questions regarding a potential concern, please call the HOPE line at 412-578-HOPE to schedule an appointment. Our topic tonight is Fueling the Fight, How Exercise and Nutrition Boost Recovery. We are pleased to welcome Dr. Colin Champ and Christopher Peluso this evening. I'd like to take a moment to introduce these remarkable individuals and showcase the impact that they're working to, the impact they're making at Allegheny Health Network. First, Dr. Champ is a board-certified radiation oncologist, diplomat of the American Board of Integrative and Holistic Medicine, and a certified strength and conditioning specialist by the National Strength and Conditioning Association. He came to Allegheny Health Network from Duke University Medical Center, where he was an associate professor in the Department of Radiation Oncology. He has an active patient clinic specializing in the treatment of patients with breast cancer and lymphoma, and has been voted by his peers as one of the best doctors in America. His research focuses on both cancer treatment with radiation therapy and interaction of nutrition and exercise in prevention and treatment. He published the first case series on the use of the ketogenic diet during treatment for high-grade brain tumors and has been invited to lecture on his research around the world. He is also the director of the Integrative Oncology at AHN and head of the Cancer Institute Exercise Oncology and Resiliency Center based at Suburban Hospital. Dr. Champ received his Bachelor of Science in Chemical Engineering from Massachusetts Institute of Technology and did his medical degree and specialty training at Jefferson Medical College at Thomas Jefferson University. He has published over 80 peer-reviewed studies, wrote 2 books on nutrition and exercise, and has contributed to multiple textbooks as a reviewer for dozens of scientific journals. Dr. Champ is a powerful voice in promoting a healthy lifestyle, diet, and exercise for the treatment and prevention of disease. His work in this area has been featured by popular media sources, including the Boston Globe and Sanjay Gupta. He joined AHN in 2022 as an associate professor of radiation oncology at Drexel College of Medicine. Christopher Peluso is a master's trained exercise physiologist, strength and conditioning specialist, and the supervising lead at the AHN Cancer Institute's Exercise Oncology and Resiliency Center. He completed his bachelor's training in exercise at Mercyhurst University and his master's training at the University of Pittsburgh in exercise physiology. Specializing in musculoskeletal science, exercise oncology, and human performance, his work combines biomechanical analysis, clinical insight, and advanced strength training methodologies to create effective personalized weight training strategies for designing and implementing weight training prescriptions for both research purposes as well as long-term trainees as a form of physical muscle forward medicine. Welcome, Dr. Champ and Chris, and I will turn it over to you and we'll take it from there.
All right, great. Can you see my slides okay?
Yes.
All right. So tonight we're going to talk about fueling the fight, how exercise and nutrition boost cancer recovery. Chris and I will go back and forth discussing several topics throughout. This is a picture of our exercise facility in the background. Thanks everyone for coming out. So it's an exercise facility, but we do more than exercise there. We talk about nutrition. We have sit-down sessions where we talk about nutrition. We have sit-down sessions with Chris where we talk about exercise, mobility. We have mobility sessions. We have multiple studies running at any given time. And it's a total immersive type of a center. Again, not just a gym, not just a nutrition center. It's kind of all the above. This is our mission and philosophy, and there's a lot of words going on here. So I'm just going to highlight a couple of them before we start. with the presentation. Really, the crux of this is to increase muscle mass, bone density, and decrease adipose tissue, which is improving overall body composition. This has been shown to correlate with good outcomes or better outcomes after treatment for cancer. And then also improve the physical limitations that may have occurred during cancer treatment, improving sleep, quality of life, et cetera. And really doing all this in a setting where it's collegial and fun and everyone gets along together and is part of this journey together. Here's, sorry, a little delay in my slides. Sorry, there's a delay. There's a couple pictures of our center. It's about 4,000 square feet. We have an adjacent lab next to this where we do a lot of our research. There's a big turf down the middle. You'll notice lots of weights, no cardio equipment. That's all by design. We want to get as much done as we can in the short amount of time that you're with us. All right, so we'll start the talk now. So cancer and cancer treatment side effects can be all encompassing. These can range from top left here, issues with performance, physical function, top right, neuropathy, our neurologic system not functioning appropriately, loss of muscle mass, increased fat mass, loss of strength, decreased bone density, and things like loss of cognition. So these are all the things we want to try to limit. We can't necessarily limit them from some of the treatments because some of the treatments, no matter what you do, are going to cause these side effects, and cancer itself can often cause these side effects. But what you'll notice is when you look at these side effects, they're quite similar to the side effects of aging. The difference, of course, is that these side effects can happen quite acutely. You can get neoadjuvant chemotherapy for breast cancer with ACT before your surgery, and after a couple months, you feel like you aged about 20 or 30 years. And it's not just in your head. This can happen from treatment. So it's our job to try to offset these side effects. But again, I do want to focus in on the fact that these are similar side effects to aging and similar side effects that we're all going to experience in life. So I'm going to have Chris start us out talking about muscle mass and a little bit on fat mass and strength.
All right. First and foremost, muscle mass, super important for longevity and its relation to mortality. First study here, you have a group of about 3,700 study participants, and compared to the National Health and Nutrition Examination surveys, that group was about 4,300 people. If you look at the graph here on the right, bottom right there, a couple different lines here. Each of them are all kind of on a downturn for survivability. But if you look at the top two groups, there's a small dotted line and a full thickness black line. This is the top half of muscle mass index, which is essentially muscle mass in relation to your total body weight. As your muscle, in layman's terms, as your muscle mass increases, your survivability will also increase. If you look at the bottom there, that's in a span of months. So as you gain or have more available functional muscle mass on your body, it essentially adds months to years to your life. On the contrary, something that we're all trying to reduce, or at least should be, is fat mass and its relation to mortality. So 4 different graphs here. This is a study that controlled for age, follow-up time, liver fat, and subcutaneous fat. If you look, each one of those has a slight rise as either poundage of fat increases or surface area of the fat increases. And we're talking about visceral fats, fat surrounding your organs. So no matter what you're looking at, if you're looking at physical poundage or the all-encompassing surface area of the fat, it'll increase. And as this increases, odds for mortality also increase. Let's see, going on to the next one. A lot going on here, whole bunch of different studies that they looked at. On the right side, hazard ratio. Essentially, if you look at those numbers, greater than 1 on that scale is an increased risk of mortality. Less than 1 is a decreased risk of mortality. So if you're looking here, sarcopenia, which is generally defined as low muscle mass, and we'll talk about this a little bit later with sarcopenic obesity, but for now, sarcopenia is essentially low muscle mass in relation to total body weight. As sarcopenia increases, risk of mortality also increases. And the inverse is also true. As sarcopenia decreases, the risk of mortality also decreases. Go. Another one, this one. So volitional fatigue, often defined as failure. It's essentially the point at which, when you're doing an exercise, you can no longer perform repetitions to the correct technique or repetitions at all. You can no longer, if you're doing a push-up, you can no longer do any more push-ups any further. This is a key principle in what our standards are, and what a lot of the research points to in terms of gaining muscle. If you look there, what do we got? Six different graphs here. Top left, this is comparing high repetitions to low repetitions in training. Often when you use high repetitions, you use less weight. When you use low repetitions, you use quite a bit more weight just because of capability. And if you're training to the point of failure, the weights for low repetitions are going to be significantly higher than those of high repetitions. But if you look at the top left, what this graph is essentially explaining, type 1 cross-sectional area. Type 1 is a type of muscle fiber. It's normally a little bit better at enduring higher volume per se, higher volume no matter what the exercise is. So in elite marathoners, you often see higher concentration of type 1 muscle fiber. Nonetheless, we're talking about weight training here. The high repetition group seem to increase cross-sectional area of their muscle fibers versus the low repetition group. If you bump down one graph, this is looking at type 2 cross-sectional area. And cross-sectional area is essentially the surface area of the fiber when you take a biopsy of it. Type 2 muscle fiber is, I would say, more along the lines of power-producing muscle fiber. So it's not going to be able to endure as much volume. You see this more often with short distance sprinters. They're going to have a higher composition of type 2 muscle fiber. But simultaneously, this is I'd say, more important muscle fiber to look at. One, as we age, and two, as we become more sedentary, whichever comes first. And also within the cancer population, because, like Dr. Champ was explaining, the side effects of cancer treatment very often resemble those of aging, to a point that I made this point to him earlier today. It's like the cancer treatment process is almost artificially aging you. But type 2 cross-sectional area, it seemed to fare about the same for both groups, both high and low, before and after. If you go down one more graph, this is looking at fat-free body mass, with the low repetition group fared a little bit better in terms of total weight, total fat-free mass gain. All of those graphs on the right, those encompass all of the different training regimens. The first is type 1. The first graph is type 1 cross-sectional area. Again, low repetitions seem to fare a little bit better. Type 2, likewise. And for fat-free body mass, the same went for it.
Thanks, Chris. So Chris touched on the importance of having a lot of muscle mass. That was in the general population. So the more muscle mass you have, generally the longer you live. Best way to put on muscle mass is through resistance training. If you go to volitional fatigue, it may not matter exactly what kind of training you do, but the key is to get people to volitional fatigue, right? To get people to the point where by the last rep, they're unable to do any more. The kind of exercise that, just being frank, few of us would do on our own or in our basement. So now we're going to talk about both strength within the presence of muscle mass as well, and also the impact of fat mass. So while muscle mass is important in the general population, strength has been shown to be as important, if not more. This was a study in just over 2,000 people. These were healthy aging individuals, and what they found was in the top here, when they did a leg extension, their quad strength correlated very strongly with how long they lived. And so the strongest individuals had the highest curve here, so they lived the longest, whereas the weakest individuals had the shortest lifespan of them all. And when you look down at the bottom here, this is something really interesting, grip strength. This is something we do on all of our individuals at our center. We do a grip strength before, sometimes during and after each workout regimen. And grip strength strongly correlates with survival. So the stronger your hand is, the longer you live. And there's a lot that goes into that, and we could do a whole nother lecture on that. But again, strength strongly correlates with mortality. So anything that makes you weaker, you're going to want to try to offset that weakness to get your strength back. And this has been shown in a similar meta-analysis like the one Chris showed on sarcopenia. Here you see the exact opposite. This was 38 studies and almost 2 million individuals. Anyone here on the left had a longer survival, and that was strongly, no pun intended, that was strongly correlated with strength. So the stronger individuals here lived longer. And you see this overplay with muscle mass, like what Chris was talking about, strength, like what we're talking about here, and fat mass. And again, this is just looking at the overall population, no one that's been through treatment, just a general person walking down the street, what correlates strongly with their survival. And this was an interesting study because the top two lines here, those are the individuals that lived the longest, the orange and black. That was looking at no sarcopenic obesity, so none of what Chris talked about, no low muscle mass, no high fat mass. But what was interesting is individuals that had one of those, either excess fat or low muscle mass, but their hand grip was normal, they actually lived just as long as the other individuals. So again, there's something unique about hand grip strength that really correlates with how long you live. And then you see a stepwise decline here. And then the people with the worst survival had low hand grip strength and had low muscle mass and low fat mass. And on the right here, if you actually look at individuals with a high BMI, so individuals that you would think have excess body fat, you see the same exact relationship. So BMI is not a great way to judge people. Weight's not really a great way to judge health either. You want to look at muscle mass, you want to look at fat mass, and you certainly want to look at hand grip strength. So our number one goal on a daily basis is to get individuals stronger, to get their strength back, ideally to increase their strength. They're getting chemo to help offset and stop the loss of strength. And there's only a couple ways to do that. We're going to talk about it. And the world of exercise oncology, which is really a new field, initially a lot of studies were, sorry about that, very scared about side effects in these individuals, and rightly so. Sorry, there's a delay. So what we're trying to do is really push the bar. And this is an example of a study. This is a famous study, but of what we're trying to go past and move beyond. This was a study with about 150 women with breast cancer. They wanted an exercise regimen at home twice a week for a year, and then they came back and underwent testing again. And what's bolded here or outlined in red is bench press and leg press. So the individuals that started, their bench press was 41 pounds average, and their leg press was 170. After a year, their bench press increased to 54 pounds, and their leg press increased to 213 pounds. So those are changes you generally want to see. Let's say in a non-cancer population, you'd see those changes in about a month. So why in a year are you seeing that? The point of this is that we need to step things up. We need to do it in a safe manner. And also, if you looked at lean mass in this study, after a year of exercise, these women on average actually lost muscle mass. It went from 46.8 kilograms of lean muscle mass to 46.25. So this is exactly what we don't want. So the first question we asked at the Exercise Oncology Center was, can we improve strength and muscle mass during and after treatment? So not even can we stop it from decreasing, but can we actually improve it? We did a 3-month intervention. This is the same 3-month intervention that anyone who comes through our center goes under or goes through for 3 months, 3 times a week. The majority of the women that underwent this study, this was for women with breast cancer, had no history of a prior exercise regimen. Most of them were on Arimidex, and most of them, about a third of them were receiving radiation therapy during the workout. We had them do split squats, trap bar deadlifts, incline dumbbell press, bird dog rows. We measured the weights they were lifting in what's called load. That was like the dose of exercise. Then we did functional movement screens, wide balance assessments, body composition testing with a bioimpedance analysis machine and an ultrasound, and then quality of life questionnaires. This was really, the first study was really a safety study, but we did want to see obviously what happens to the strength and muscle mass. And really to our surprise, you see here on the top left, muscle mass gain. This is in pounds. So they gained about 1.5 pounds of muscle mass in 3 months. Their percent increased by about 2%. So it's actually a pretty decent gain of muscle mass, particularly while you're going through cancer treatment. But more profoundly, they lost over 5 pounds of fat during the 3 months. So they, on average, gained muscle and lost fat, which is like what everyone wants to do when exercising. The percent fat loss was about 3%. And then excess fat loss, we measured this during ultrasound, was about 4 pounds. Then if you look to the right, grip strength increased bilaterally by about 6 pounds of force. And then Y balance left and right increased by about 15. Now that probably doesn't mean a lot, but a lot of these women went from a fall risk to no longer a fall risk based on the changes. And the load lifted is what we measure. And so just for insight, if you look at load of trap bar deadlifts, so on average, each week they were lifting 2,493 pounds through the deadlift. And when they finished, they were lifting 3,120 pounds. So pretty profound change. The exercise regimen was certainly intense. To our knowledge, one of the most intense tested in women with breast cancer. So then the question, of course, is this safe? And so understandably, when we pushed this regimen, people were very scared, particularly about lymphedema. Now, there is a plethora of data showing that strength training improves lymphedema. Question is, would it improve it if it's this intense? So we looked at 115 women that underwent one of our 3 studies, Exert C, BCN, or BC. You'll notice the average age is 54, and a handful of these women had axillary dissections. and about 13% of them had lymphedema at the start of the study. And that's clinical lymphedema or lymphedema on our machine that can test it. Our machine tests fluid levels, both intra and extracellular in the arm. So you can tell if the extracellular fluid levels start to exceed that of the initial analysis. You can tell that lymphedema is increasing, and vice versa if lymphedema is improving. So what we found is that all women who underwent this study increased muscle mass in their arms by a fraction of a pound, but this is just in their upper extremities. And if you look at the extracellular water in their upper extremities in the muscle versus non-extracellular, you see a decrease. So what that signals is that lymphedema actually improved in these women, and really in both arms, but particularly when you compare their affected arm versus their unaffected arm. This did fall out in the axillary lymph node dissection group initially, but when we actually adjusted for muscle mass, you still saw. So not only is it effective, it's safe, and it decreases risk of lymphedema. So then the next question is, so we talked about muscle mass, how to increase muscle mass. We talked about the importance of strength. So what do we do about fat mass? And I'll try to speed up here a little bit. So again, if we look at the general population, someone walking down the street, man or woman, cardiovascular disease strongly correlates with having low muscle mass and high fat mass. And this is on the top here is women. So you see a stepwise decline in survival without cardiovascular disease as you drop from high muscle mass and low fat mass. And then on the bottom here are individuals with low muscle mass and high fat mass. Interestingly, for men, low muscle and high fat have the highest coronary vascular disease mortality. If you have high fat or low muscle, it doesn't matter. They're about the same. And then if you have high fat and low muscle mass, you see a high risk of cardiovascular disease mortality. In breast cancer patients, unfortunately, what we've experienced, if you look at data from the 1970s to 2010s, what's good is you see a significant decrease in risk of dying from breast cancer. And these are the black dots here. There's a 70% risk of dying from breast cancer after diagnosis in 1970. That reduced to 30% by 2010. The problem is a lot of those women were dying from something else and not that long thereafter. And that's the green dots here. That's death from a non-cancer. So we're curing breast cancer, but then there's some other issue that's plaguing these women and shortening their mortality. And if you look to the right here, this is basically what it is. There's a bunch of dots here, but that SIR on the left axis, that's your risk times the general population. So 10 times is that middle line there, and the line one up from there is 50 times. So if you follow that to the right, the first pink dot, the second pink dot, that's average breast cancer patient from age 40 to 44. They have 50 times the risk of diabetes versus the normal population. So that's what's happening, right? They either have other metabolic issues or we're causing metabolic issues, curing their breast cancer, but the metabolic issues are still shortening their life. And we see this play out in real time. This is very similar to the data Chris showed you. This is data in cancer patients where they use CT scans to see how much muscle mass they had. On the left here, individuals that were sarcopenic, i.e. had low muscle mass, are in orange. They had a shorter survival after treatment. Individuals that were not sarcopenic with normal muscle mass lived significantly longer. In the middle here, women with radiodense, so nice dense muscles, lived significantly longer than those that had not very dense muscles. And then the right here, the more adipose tissue an individual had, the shorter their lifespan was. So again, it's not just cancer patients, it's anyone walking down the street. The more muscle mass you have, the longer you live. The less fat mass you have, the longer you live. So number one, to increase muscle mass, which Chris already talked about, is damaging the muscle through exercise, tearing the muscle, causing it to grow back stronger. The next thing you need to do is feed that muscle mass with protein. The RDA used to recommend 0.8 grams per kilograms. That's about a third of a gram per pound. So if you are a 150-pound ideal body weight individual, that's 54 grams of protein. If you weigh 110, that's 40 grams of protein. These are based on older studies. There's few elderly studies. They didn't account for chemotherapy, other issues, cancer treatment, et cetera. These are way too low, and they're being totally flipped on top of their head. Newer data is saying you want more than a gram per kilogram per day, and you want to get 20 to 30 grams per meal. Ideally, overall, especially if you're trying to prevent muscle loss or increase muscle mass through exercise, you want over 1.2 to 1.6 grams per kilograms. Easy way to think of this is basically 75% of your ideal body weight in grams of protein. So if you ideally should weigh 100 pounds, just for a nice even number, you should eat, this is 73, but 75 grams of protein, you should be good. It should be greater than 20% of your energy intake. And that's specifically for individuals with metabolic changes during aging, which is all of us on here tonight, weight loss, inactivity, type 2 diabetes treatment, metabolic syndrome, or cancer, chemotherapy, radiation therapy. These are all similar events that can cause cachexia. So you're going to need to increase your protein. And unfortunately, if you look at the average man and woman walking down the street, most of us don't eat enough protein, certainly at breakfast. And that's because we're staying up too late on our devices, watching Golden Girls and Murder, She Wrote. And then at lunch, we're also generally not great with protein either. Dinner, we generally catch up. Women on average do not eat enough protein. This is something we see in the gym again and again. So the next question we asked is, so it's great that we can improve strength and muscle mass. Can we actually improve fat mass at the same time through diet? This is a similar study, a little bit more people than the last study, Exert BC. So what we recommended, exact same exercise regimen. We had them increase their protein to 0.6 to 0.8 grams per pound per day. So that same 75% per day, and then keep carbohydrates under 100 grams per day. This is based on the Diet Fit study, which is a randomized study showing that this works quite well to reduce weight in adipose tissue. The 4 tenets of this, which I think are very important, because these are more social cultural, were no calorie counting. We didn't tell you to limit. We told you to eat nutrient dense foods, get more bang for your buck. Just like with Chris's exercise regimens, he wants to get you to volitional fatigue. There's a couple different ways to do that. We want to do the same with nutrition. We want to get you the highest vitamins and nutrients possible. Limit processed foods, sugar, bread, pasta. Cook and eat with your family. No snacking. Don't eat in the car. If you're getting up late, pounding a yogurt or eating a Kind bar in the car, you got to go to bed earlier. This isn't a food issue. It's a time management issue. And then quality is always better than quantity. We don't say don't eat red meat. We say eat grass-fed red meat, eat whole foods, etc. And this is something we talk about a lot at our nutrition sessions. I like to bash oatmeal at the nutrition sessions, and I hope the person I always talk about that too is on tonight, because he'll be laughing right now. But again, when you think of fiber, protein, carbohydrates, you want to get your biggest bang for your buck. And this is what we tell individuals all the time. This is what we did in this study. If you look on the left here, if you eat plants for fiber, the best reason you eat plants is for fiber, to feed your bowel bacteria. There's also chemicals in there and polyphenols. So you want to get the highest fiber amount. And if you look on here, eating things like long grain rice, white bread, quinoa, whole wheat bread, doesn't matter, oatmeal, you get this huge amount of carbohydrates. Look at oatmeal, 56 grams of carbohydrates for 8 grams of fiber. So the fiber to carb ratio on that is 0.14. That's not a good business transaction. If you look further down, eat something like kale, you get 7.3 grams of carbs in kale. Over almost 40% of it is fiber. That's a fantastic business transaction. Eat all the kale you want. Put olive oil on it, salt and pepper, bake it. You see the same with carrots, broccoli, almonds, okra. These are great business transactions. Okra's over 50% fiber, right? Great business transaction. On the right here, we always have individuals come in and say, I'm getting my protein from plant sources. Plant sources are also not a great way to get protein. Now, if you can only eat plants, we work at it, we figure it out. But if you go down the line here, most of these plants from a cost perspective with carbs, et cetera, not a great source of protein considering what you're getting. Whole wheat bread, look at that. You get 12 grams of protein to 42 grams of carbs. Again, not a good business transaction. Almonds start to get better, right? It's a 1-to-1 protein to carb ratio. You're going to get some decent fat in there as well, some good polyunsaturated fat. Nuts are a better source of protein for sure. Grains, these other foods, are not a good source of protein. What we saw when individuals follow this diet The average body fat went from 32.3 pounds to 30.5. So that's a 6.6% change in percent body fat. So a huge difference. It passed our statistical thresholds. They gained 1.4 kilograms 1.4% muscle mass gain overall. It was about a pound and a half, much like our other study. So that, again, they lost fat mass, they increased muscle mass, fat-free mass increased by about 2.2 pounds. Phase angle, which is the fluidity of your cells, improved. Their carb consumption went from 141.9 grams to 92.8. This is via surveys, and their metabolism went up. Interestingly, if you look at what predicted muscle mass change, women with a higher baseline BMI generally had worse results overall. They lost more muscle mass with fat mass loss. What was interesting on the bottom here, whether a patient was on Arimidex, radiation, a systemic therapy, didn't matter. So it did not matter what treatment you were getting. As long as you showed up, you lifted weights, and you changed your diet like we asked, you saw improvements. This is extremely encouraging. This is extremely empowering. Don't let anyone tell you because you have cancer or because you're getting cancer treatment, you can't do these kind of things. You can't exercise. You can't change your diet. This is now a protocol that we have for women undergoing chemotherapy before surgery. They're on very nasty chemo. They do amazing on this study. And so I'm going to pass it to Chris. But one thing to note is, as we go through all of these different side effects of aging and chemo, you start to see that the way to improve these significantly overlaps. So Chris, I'll hand the mic back over to you.
One thing before I move forward with the Q&A, should I address these now or should I wait till the end?
No, just wait.
All right. All right. Moving on. Let's see. I got a little bit mixed up here.
We're on neuropathy, bone density, and falls.
Yep. All right. Looking at breast cancer outcomes and activity levels. We have a graph on the left here. This was both of these graphs represent the same study. It looked at 1,340 women treated for breast cancer. If you look on the left, there was a reduction of recurrence and death as activity was introduced in year 1 and year 2. If you look here on the right, there's a significant reduction in mortality as activity levels got into the higher range. If you look at the low and moderate activity, they seem to be about the same in terms of how much they reduce mortality. So kind of going back to my point earlier and kind of what we've been harping on this entire time, activity level before, during, and after chemotherapy is super important, especially in the higher range. And there's a million different reasons how this could improve lifespan, how it could decrease mortality. But in general, activity level at higher ranges is going to reduce mortality before, during, and after chemotherapy. We have another aspect, cognition, and I would say more so in the past 5 years, 5 to 10 years, cognition and activity and exercise in general has been on the rise, and research combining the two, looking at the two, has been, I'd say, quite on the rise. But if you're looking here at the graphs on the left, we have 3 of them. The top left there, the left side of the graph is showing essentially glutamate and glutamine complex to create total creatine measurement. It's just a simple neurochemical marker found in the brain, in the sensorimotor cortex. As as you increase those neurochemicals, if you look at the bottom range there, strength of general knee extension also increased. If you go to the right side here, the right graph is looking at the same or similar glutamate to glutamine complex to create total creatine measure. This is in the prefrontal cortex. I'm sorry, I mixed that up a little bit. So the first graph was reduction in these neurochemicals, increased patient knee extension. Second graph here on the prefrontal cortex showed very similar findings. And likewise on the bottom there, I was looking at a little bit different marker. I was looking at myo inositol to total creatine instead of glutamate, glutamine complex, and very similarly, as that decreased, knee flexion increased, so strength increased. So what we can kind of conclude from this is as inflammation reduces, because that's what this boils down to, as the inflammation in the brain reduces, or inflammatory markers in the brain reduce, strength increases, and vice versa. As strength increases, reduction in brain inflammation is also prevalent. All right, falls and fractures, very important, especially with cancer patients because of the treatment regimens everyone's on. A very common side effect of treatment is reduction of bone density. But the main thing here, falls increase with any cancer, more specifically with breast cancer, but all in all, falls increase as cancer diagnoses, cancer treatment happens. Two of these different measurements for fractures. Hip and vertebral fractures, very debilitating. If you experience one or both of these, it can make you sedentary permanently or debilitate you long term. But in any cancer, the risk of fracture increases exponentially. If you're looking over at the right here, it's looking at lumbar spine and total hip bone mineral density changes. So the solid line were women not on arimidex, so aromatase inhibitors. On both graphs, the solid line represents not on arimidex versus the dotted line were women on arimidex. It's pretty clear. The common theme is that arimidex reduces bone mineral density significantly, especially over time. You often see arimidex being prescribed longer term, 5, 7, 10 years. But this kind of reinforces the point that strength training or bone stimulation in general, which seems to be best stimulated by strength training, is very important, especially for anyone undergoing breast cancer treatment who may be on longer term estrogen therapies. But one main concept of building bone density is minimum essential strain. This is essentially it's about 10% of the force needed to break the bone is what will stimulate the bone to lay down osteoblasts, or stimulate osteoblasts to lay down new bone. So for the femur, for example, which the picture showing you there, for the femur, anywhere from 900 to 1,300 pounds is the force needed to break that bone. So you need anywhere from 90 to 130 pounds of force put onto that bone to stimulate some sort of bone remodeling, bone growth, which ends up resulting in bone density increases over time. There's a bunch of other factors that are involved with this. Two being vitamin D and vitamin K consumption, whether it's from your diet, supplementation, very, very important. Calcium, of course, as well. But similar to what we had talked about with muscle building, your bone needs stimulated similarly and intensely. The changes in bone density are going to be much more drawn out. So you're not going to see great short-term changes. It's going to take anywhere from 6 to 18 months to see significant changes in bone mineral density. But looking over to the graphs on the right here, you have gymnasts, runners, and controls. Overall, it seems gymnasts had the greatest bone mineral density changes. If you think about gymnastics, it's a lot of jumping, a lot of pounding on the bone, a lot of torque on the bone, twisting, pulling. So essentially, you're stimulating the bone from all different angles at relatively high forces. So in a very intense manner. Whereas runners, on the other hand, runners are undergoing long, smaller impact, longer duration impacts on their bone, and it seems that running doesn't necessarily increase bone density as well. And if you think about the nature of running, running is in a straight line very often. A straight line, maybe circles if you're running around a track, but not enough to torque the bone. It's generally a direct contact, ground impact on each stride, each step. Moral of the story here is higher intensity, short burst, powerful activities like jumping per se. Those of you who are watching that are in our program, this is why we do our jumps before we work out. Part of the reason why many other exercises, including axial loading with barbells, deadlifting, all are going to stimulate bone density. But I would say in general, the easiest way to stimulate bone growth or bone mineral density change is something along the lines of jumping that you would see in gymnastics. Of course, not to that extent. It's not universal. Not everyone can go and start gymnastics immediately. But jumping in general, that's the theme here that seems to cause the greatest increase in bone mineral density change. And another thing, so on the topic of bone density, two graphs here, high impact exercises, like I was saying, promote bone density increases. This study was in well-trained individuals, specifically females. On the left-hand side, on the left graph, you have forearm bone mineral content. It's a small bone. It doesn't normally withstand a ton of impact. You would see a lot more impact on your femur, your tibias, your hips. But forearm bone mineral content increased as bicep strength also increased. So if you're doing bicep curls, very simply put, as you increase in strength on bicep curls and your biceps, your bone density of your forearm will also increase. If you look over on the right, this graph is showing bone mineral density of the femoral neck, so the part of your femur that's closest to your hip. Very often you see fractures here, but as an interesting point here is as femoral neck bone mineral density increased, biceps strength also increased. So this is kind of showing, I would say, more of a total body picture here. So as you increase strength throughout your entire body, you see an increase in bone density in general. So it's better, I would say, all in all, very important to train intensely, specifically to stimulate muscle growth. So as you increase muscle fiber stimulation through exercise, through weight training, you get a ton of neuromuscular benefits as well. So aside bone density and strength, you increase neuromuscular recruitment, stimulation to the muscle fibers, increases muscle size, strength, power, mobility, nervous integrity. So the nerve that connects to the muscle fiber that contracts when you do a bicep curl becomes better developed. You essentially have a better feel for it. You become more coordinated. So the movement that you're performing feels smoother. And often accompanying that is greater balance as well. But we had talked about this previously, how the aging process and the physiological adaptations per se to cancer treatment are very similar. I was going to say, if you go in reverse on this from top counterclockwise, you often see this is what would kind of demonstrate what happens with aging, what we see with aging, and what we see with intense cancer treatments like long-term chemotherapy. If you go counterclockwise from top all the way around, you see a decrease in balance. If you're sedentary, you see a decrease in type 2 muscle fiber, so power producing muscle fiber. You see a decrease in motor unit integrity, mobility decreases, power output, like I was talking about with muscle fiber composition shift, power output decreases, strength decreases. So as you age or as you become more sedentary because of possibly a really, really intense treatment, you see these all-encompassing decreases in your anatomy and your function, which is kind of the the bottom line to why we do what we do, why we push individuals and patients so hard, and simultaneously why we're careful to not push them too hard, because if you push them too hard, you'll kind of reset yourself back to square one, which is, it's a fine line we walk. And luckily, we don't deal with many injuries, many overuse or overreach situations. But nonetheless, intensity is very, very important with what we do. And none of these physiological processes, improvements are going to be completed to the fullest extent without it.
All right, thanks, Chris. I'll speed through these last couple slides just so we can answer some questions. So you see the whole loop, the full loop here of how to offset the side effects of cancer treatment and aging. I would throw in, this is not for home. This is a study where they took advanced athletes and they had them exercise at home or in person, and they tested their squat strength, their bench press strength, and hypertrophy, and it was all improved across the map for individuals that were training in person. You're always going to see better benefits doing this in person. It's going to help ensure safety. There's actually a 27 study meta-analysis that shows this. If you send a cancer patient home to exercise, it's basically a coin flip as to whether they're going to do it or not. Decreased adherence is associated with fewer contacts with participants, no supervised element, no exercise prescription, and limited social support. So that's why you want to come into a group where you can get all of those things. Unfortunately, in our first study, when we sent people off on their own, a lot of the benefits that they saw from the program, they ended up losing. Interestingly, whether they kept exercising or not, they kept the increase in grip strength, Y balance, functional movement screen. So it's like learning how to ride a bike. You keep the neurologic benefits, but the muscle mass and fat mass benefits wore off. So we now have everyone stay on if they can. And going back to our philosophy, so our center in the crux of our center here is that it's not a gym, a weight room, a group fitness class, or an exercise center. It's a medical facility. We've seen thousands of patients combined, so we have a pretty good understanding of how to deal with all the different intricacies that can come with cancer treatment. Everything we do is backed by published results. You should experience the same results if you follow our exercise prescription. One thing, lastly, to keep in mind is to achieve the above benefits requires intense exercise that may promote discomfort. You may get sore, and we're not opposed to expected soreness and discomfort during and after a workout. Exercise is basically making your body uncomfortable so that it can grow back stronger. So thanks, everyone. I will rip through some questions here. If it's okay, Chris, I'll throw some at you that make more sense, and then I'll answer a couple. One question is there research showing that exercise can prevent or slow the growth of existing cancer cells? So prior to last month, they were all Petri dish studies, but last month a study came out. This was in patients with colorectal cancer undergoing treatment. They put them on an exercise regimen. I forget how long it was, the actual regimen. I think it was 6 months to a year. There's a 10% improvement in survival and progression-free survival. So that's a huge number. Like if that was a drug, it would be a blockbuster, multi-million-dollar drug. So that was the first study to show. We expect many more to come. That study required thousands of people, millions of dollars, and a lot of effort. So those studies are going to be slow to come. But other studies would suggest you're going to see a similar signal in other cancer types. Chris, great question here for you. Does strength training to volitional fatigue risk overuse, overreach, or overtraining in some cancer patients? If so, under what training conditions, i.e. regarding training variable manipulation?
So I started getting into this a little bit at the end. It's a fine line you have to walk. But one thing that I really want to emphasize, because you don't get a ton of the benefits that we've mentioned. You don't get the neurological benefit. nearly as much of the bone density benefit or the muscular benefit from weight training specifically when you underdose exercise. So the overuse, overreaching, like I said, this is a fine line you have to walk. I mean, it's as simple as constantly surveying patients, is constantly asking questions, seeing the body language of the patients, seeing how well they move, asking about aches and pains, and refining and adjusting as we go. We can always reduce the weight. We always overemphasize good form. Training to full range of motion is another big reason, but a couple things aside from constant surveillance of the patients, incorporating prescribed rest times is a really, really big concept that we like to use. Increased rest times with more power output, neurological training like heavy strength training, slight reduction in rest times for higher volume. But the main thing is having a prescribed rest time. This helps with recovery, and more along the lines of what Dr. Champ was saying. What Dr. Champ was saying is adequate protein intake is going to help repair the muscle a lot more. Or higher, I'd say higher protein intake at that. Rest, sleeping. You grow the most and recover the most when you're sleeping, not when you're performing the exercise. Limit blue light at night so you have good restful deep sleep. Limit caffeine consumption throughout the day. Massage is always a response to it. So if you're pushing hard, you're going to get sore. If you're getting sore to the point where you're debilitated for more than a couple days, I would say then institute those I'd listed before. Better sleep practices, better nutrition, increase hydration, electrolyte consumption. It's a long-winded answer. It was I wouldn't say a loaded question. It's everyone's concern. I don't want to go too hard and hurt myself, because the general population, along with cancer patients and exercise oncology, we all have the same concerns.
Thanks, Chris. A couple of questions on the protein. The protein, that grams I gave is for ideal body weight. So you can look up online, what's my ideal body weight based on height, et cetera. How do you increase protein again, especially at breakfast? You get to bed earlier, number one. Stop watching TV at night. No devices at night. And then if you don't eat meat, eggs are a great source of protein. Nuts are a good source of protein in the morning. Fermented dairy, really fermented dairy like kefir, is a pretty good source as well. Not the fake yogurt stuff where they just throw a bunch of sugar in. Chris, someone asked about anaerobic versus aerobic workouts. Can you explain how? I think they meant cardio. Can you explain how we do cardio at the gym?
Yeah. Wait. Oh, here we go. What kind of cancer cells are affected by exercise, and what kind of exercise is preferred, aerobic or anaerobic? From Anonymous. So this is, I mean, you might need to tag team in here with me, but I would say overall anaerobic, you can categorize weight training as more anaerobic, but I will say we have conducted a study looking at the effects of high volume, low rest weight training as a form of aerobic. And our base study that we talked about on end, Exert BC, Exert C, those are our general studies that anyone who starts in our program starts on, which is just general, I would say for the most part, hypertrophy training. You could categorize this more as anaerobic because it's more short burst style training. But I would say all in all, I think it's best to alternate. So if you're simply doing weight training, the best way to achieve your desired outcome, whether it's strength, muscle growth, or hypertrophy, I would, or even we'll say cardiovascular improvement, is with weight training is to complete that style of training for an extended period of time. I would say anywhere from 4 to 8 weeks. As you become more experienced with training, it's going to be the time that you need to train is going to be less. As if you're a newer trainee, you can train up to 8 weeks doing the same training program. But I would say overall, the training style that you should go for is going to be more, I would say, anaerobic for muscle building purposes, bone density improvement, specifically for cancer patients.
Thanks, Chris. I'll rip out 2 more here. A lot of questions on who are we taking more patients and who can qualify. We're always, it's constant. People are coming and going on the program, so that's always open. The criteria, you just have to be able to move well, like get up and down off the ground and be able to walk around a gym and work out with us. And if there's any movement issues or whatnot, obviously we'll send you to physical therapy, etc. Someone asked, why don't all oncologists promote exercise and proper diet? That's we need a couple cases of wine and about 10 hours to sit down and talk about that one. And then one more question. So a lot of questions good question on bone mineral density, a lot of questions on protein. In our study that we're running, we use a whey protein after exercise. Your body is much better at utilizing amino acids after resistance training. We use a whey. We use it unflavored, no artificial sweetener, very pure product, third party tested by lab. That's the highest biologic value protein you're going to get post workout. Collagen for muscle building is an overpriced, less effective protein. And then, do we have time for more? Or is that it?
There was one on here about bone density.
Yeah, that's a good one. You want to take it?
Yeah. So, we haven't necessarily looked at osteosarcomas, chondrosarcomas with our personal research. I would say to relate it to bone mineral density or improvements of bone mineral density, we've had quite a few patients with medically induced or medically reduced bone mineral density, whether it's from androgen deprivation therapy or like we were talking about earlier, Arimidex or estrogen therapies. And these reductions in bone mineral density, of course, have their own signs and symptoms, specifically when it comes to reduction of bone mineral density in the spine or the hips. You often see some sort of pain signal in that area or around that area. I would say anecdotally, what we've seen in our studies and in our program, just talking to the patients who've had these low bone mineral density areas, we've seen almost like a correction of the pain. Like the pain, we've heard and seen it go away throughout the study and over time. I can't say much about osteosarcomas or just general bone cancer, just because we haven't directly looked at it, and I'm unfamiliar with the research on it. But those with low bone mineral density that we've had, we load the axial skeleton all the time, 3 days a week. Well, I would say 2 to 3 days a week, we'll load the axial skeleton directly with some sort of exercise, squat, deadlift, split squat, lunge, you name it. And those patients have definitely reported reduction in pain symptoms from those low bone mineral density or possible fracture areas.
Thanks, Chris. Last question, and we'll wrap it up. A couple of people asked about supplements, creatine. This is what we do, not necessarily medical advice. Obviously, for everyone, it's different. But most people, we recommend vitamin D, particularly in the winter. In the summer, get sun. Don't burn yourself, but get sun, and you don't need the vitamin D. Vitamin K2, as Chris had mentioned, is good for pulling calcium into the bones as well. A good fish oil we have some people take, but you got to talk to your oncologist during treatment. Also curcumin, those kind of supplements as well. You have to talk to your oncologist during treatment. Creatine is a hot topic. A bunch of people asked about it. It's likely safe. There's a decent amount of data on creatine, several decades on it. There was some concern, could it, quote, feed cancer cells? And there's not really data that shows that to be the case. There is neurocognitive benefit, obviously physical benefits. I know a lot of talking heads are talking about it right now. It seems like it's safe. It seems like there is benefit to it. I would say if you eat the way we were talking about earlier in the presentation, you will get a lot of creatine naturally. So I hope that helps.
Great. Thank you, Dr. Champ.
Thanks.
And thank you, Chris, for an amazing presentation this evening. We really appreciate you guys taking a few extra minutes to answer all these amazing questions that the attendees had. Thank you all so much for attending. Please continue to join us monthly for our Head of Cancer lecture series as we focus on cancer screening, early detection, treatment, as well as survivorship. As a reminder, tonight's lecture was recorded. If you're interested in rewatching tonight's lecture, please check back on our AHN YouTube channel, www.youtube.com/Allegheny Health Network, for the full recording in about a week. This video, as well as other past lectures, are posted under the Head of Cancer playlist. Again, thank you both, Dr. Champ and Chris, for a great presentation, and thanks to all who attended this lecture this evening, and have a wonderful evening.